started. So thank you everyone for joining live, and if not, you will be catching up on the recording. So we've got Angela Jackson joining us today. She is from an organisation called KidsBack2Sport that she founded, and so we're specifically going to be discussing and talking about musculoskeletal pathology and management in paediatrics. So I will let Angela kick off, and then we'll be open for kind of questions towards the end of the session.
Great. Thank you very much indeed, Nicola, for inviting me. And I will just share my screen. Should kick in there. Let's just bring that up. And if you can just give me a nod, Nicola, to say that's good to go. How's that? Yeah, cool. All righty. So thank you very much indeed for giving up your lunch break to come and listen to me. I'm absolutely passionate about raising awareness around the differences between adults and kids. At undergrad level, we learn all about adult pathologies, we learn about adult anatomy, and the reality is we don't know an awful lot about the pediatric skeleton. And we know even less about the athletic pediatric skeleton. And yet, when we go and work in private practice, that's what we see. Parents have this idea that just because you got their knee better, you're going to miraculously have some kind of idea how to get their 10 and 12-year-old better as well. So today's just about raising awareness. There's lots more information we can share with you, but I hope by the end of it, I maybe want to leave you with more questions than answers, so that you're really beginning to think about what you do know and maybe what you don't know. I came from a sporting background. I was that young injured athlete that became a physio, very stereotypical story. But what it did was kind of left me with a feeling of, why did I get injured? Why didn't my tennis doubles partner get injured? And I look at that whole thing every year around Wimbledon and go, why did I get injured? Not woe is me, but trying to understand what brings us to get one kid injured at one point, yet not at another. And these days I've had a private practice like all of you for over 30 years, and I sold out a couple of years ago. And that really just gave me the freedom to do what I love doing, which is teaching. My two kids, Nicola and I, were just talking about them as we came on the call. They are both, or have both, played their sports internationally. Sarah still does. And what that's really given me an insight into is the whole demands on these kids that get injured. They rock up in our private practice. We give them these exercises to do, and we hope that by some miracle, they're going to come back having done them. And more importantly, it's going to have helped them get back to what they love. But actually, the reality is it's so complex because they have so many demands on them. And we need to think about that when we give out these complicated exercise prescriptions. So let me just, there we go. So we're going to talk today, just a quick whistle-stop tour about maybe some of the bigger things that I want to think about when I'm dealing with an adolescent athlete. And that word athlete is, I think, really important to explore, because when do you decide that, if any of you are parents, when do you decide that they are now an athlete? So is the little boy who's 9, who plays football, rugby, tennis and cricket year round, running around just with his schoolmates, just with the local club, is he an athlete? Well, by the fact that he's athletic, he's an athlete. So we don't want to kind of limit ourselves to thinking about, oh, well, I don't see athletes. We all see kids who are active, and those kids are athletic. And so consequently, this is about any kid that you see and trying to understand when that transition occurs between kid to adult. So here's my son. So unless you happen to live in the university town where he's playing, then you're going to struggle to know exactly what age he is. So have a good look at Andrew and think about what age you think he looks now. Now, I gave you a clue just then in that I mentioned his university, but is he 18 or is he 23, which is roughly what he was when he finished? So what can we tell by looking at him? He looks like a man, but is he? And at what point does he become a man? And so in order to help make a diagnosis, if he presented to us in clinic, then effectively we need to know our pediatric anatomy. We need to know the timing of ossification. When does he change from a cartilaginous skeleton to a bony osseous skeleton? We need to know our paediatric pathologies, and we need to know the maturation status of each and every one of them. So let's take each of those sections just as a breakdown. When we're born, the majority of the body is still very cartilaginous. And over time, through ossification centers that occur within the bones, we start to get that longitudinal growth and also changes in shape. And when I'm talking about the pediatric skeleton, I use this analogy, and I forgive me if you think it's patronizingly simple, but you've got to be able to explain all of what I tell you today to a child. And so when I'm teaching, I also teach as I'm going to teach a child. So if we just take the anatomy of a bone and we think about the shaft of the bone, or the diaphysis, that's the T-peg. As we approach that neck of the T-peg, it's the metaphysis, which is where all the blood supply is. Lots of loops where we can get lots of infections. And it's that blood supply that actually gives all of the nutrients that are required for longitudinal growth through that physis, or growth plate, the space between the golf ball and the T-peg. The golf ball represents the articular weight-bearing surface, or epiphysis, here on in, shortened to EPIP. And then we've got the sticky out bits. Think about that X-ray where you can see in the elbow here, we've got a medial epicondyle of the humerus that's got like a little space between it and the attachment of the medial collateral ligament and some of the forearm muscles. So effectively, if you look at that radius, what you can see is a very flat, in this instance, golf ball sitting on the T-peg. It's not yet ossified. And so we would need to know at what age that takes place, and at what age that medial epicondyle sticks properly down to the parent bone, because without that, how are we going to make a diagnosis? Is that a fracture, or is that a normally occurring growth plate? We don't know unless we actually understand maturation. So let's just think for a minute about the EPIPs. So these are the pressure articulating weight-bearing surface, and most of you will have heard at University of Perthes. And that's a EPIP injury where you get the breakdown in the joint surface, in the cartilage, which over time fragments, and then ultimately over about an 18-month period, it will actually regrow and reossify and reform, hopefully, a good shape in the bone. But what we're not led or what we don't often realize is that EPIPs and these epiphysitis can occur at any pressure weight-bearing surface. So this one here in the second metatarsal can also occur in the third metatarsal. Have a think about whether you know what that's called. So it's Perthes, but in the second or third metatarsal. And this one's called Freiberg's osteochondrosis. And herein starts the ridiculous world of pediatric medicine, where some bright spark called Freiberg decided to coin a diagnosis after his name. And that doesn't really help us. If we called it a second metatarsal epiphysitis or osteochondrosis, then effectively would at least know anatomically which part of the body we're dealing with. So that's our EPIPs. And what happens here is that these guys need a prolonged and protracted period off from doing their activities. This is common in our dancers and our ballet and our gymnasts, where they're up in that point types position, putting a lot of pressure through those metatarsal areas. And fundamentally, it can exceed the capacity of the bone sometimes, often with poor blood supply and potentially other factors as well. And so we have these classifications. So once you know the pathology behind one EPIP, you can then apply that to any pressure weight-bearing surface. So this becomes your differential diagnosis for any actual joint type pathology as your starting point with a young child. But you do need to know at what point those growth plates fuse, and therefore have an understanding of when this can occur and when it can't, because these are growth plate related injuries. So if the growth plate isn't active, we can't get an injury at that site. And then we've got the APOPs, and these are non-articular, and we're going to describe these in more detail because these are what you see day to day. Effectively, the APOP is a secondary ossification center, and what that does is give shape but not length. So in order to create attachments for our tendons and our ligaments, we need to develop these APOPs into sticky out bits where we can get a good solid attachment. The problem we have is, in order to allow that shape to occur and growth to occur, it needs to be open. And each area, each APOP is only open for a specific window. Let's just think for a second about the bit in between. So we've talked about the EPIPs, we've talked about the APOPs. Now we need to consider what we call the physis, the growth plate or physeal plate. As with everything in peds, it has a zillion different names. So if we now look at this this X-ray of a gymnast, what you're looking at in the one on the left is a nice space between the distal end of the radius and its EPIP that articulates with the wrist. And you can look and see the alignment there of the ulna as well. So everything's looking good. But what happens in these gymnasts is that through over excessively weight bearing through an immature growth plate, you can see in the one on the right that it's actually squashed the growth plate shut, and we call that a premature closure. And effectively, these are what we call Salter-Harris type injuries, but are prevalent in around 50 to 75% of all gymnasts. It's kind of like, yeah, I get wrist pain, but that's normal. Now, what you'll see happen is if you close that growth plate, you've just put an end to all longitudinal growth. So in the unrecognized and untreated one, that ulna carries on growing. There's nothing wrong with that. And so consequently, it shoots past and they start to get this thing, this thing called gymnast wrist. And what that really presents like is pain on the wrist, but you're going to have excruciating pain on things like ulnar deviation, where that ulna is now longer than the radius. So let's think for a second about if, say, for example, that my son Andrew was playing hockey and he presented to me with butt pain, pain at the ischial tuberosity, at the attachment of the proximal hamstring. So think about what you're going to give him as a diagnosis. Pain on let's say deep flexion, pain on deadlifts, pain on sprinting, and any flexion-based activity in his butt at the point of the attachment of the hamstring to the ischium. So make a mental note for me of what you're going to call that if it presents to you as an adult. Now, my question is, do you know if there's another diagnosis it could be if we prove that he's not an adult? And at what point does that APOP attach to the parent bone? So when does the ischium become at one with the parent pelvis? Because we need to know that if we're going to be able to make a diagnosis. And you may be surprised to hear that the ischium isn't fully ossified until around the age of 23 to 24. So basically, if they look like a man, it doesn't mean their skeleton's a man. And so you need to then become aware of these ossification center timings. The numbers in red effectively are when those growth plates become active. When do they appear? And then the green is when do they fuse? And on the KidsBack2Sport website, what you'll see is that you can go there and download all of the different ossification centers that I've collated for you there, so that you can make them into PDFs that you can have within the clinic so that you can use them for quick reference. I'm not going to pretend to you that I know all of these off by heart all of the time. It's good to have a reference point. What you can see there is that if we look, for example, at the adductors, fusion age 20 to 30, big window, and that's because some are more mature and some are less mature. On average, the girls fuse about 2 years earlier than the boys. But I think what's important here is that we begin to look and go, anywhere that a muscle attaches around that pelvic rim has a susceptibility to avulsing up until the point at which they've fused. So at what point do we think that these guys change from being an adult, a child, to an adult? So the next part of this is, you saw that there was quite a big difference between whether when they might have fused by and when all of them will have completed that period of fusion. And that's because of this picture. You can see that all these little boys play in the same football team. Let's assume that they're all 9 years of age. But little guy number 11 has got a bit of growing to do. That might be because he's always going to be small, but it might be that he's just later to develop. And then you've got number 4 and number 16, who are massively taller, nearly a foot taller at this point. And so there's massive disadvantages to either being small or either being a late developer who's not yet grown. And that can impact how much food they need, it can impact how much rest they need, and the intensities that they have to work at. Just think about that poor little kid at number 11 and how hard he's going to have to work just to keep up. Doesn't mean he's not as talented, but what it sure as heck means is he's going to burn through more energy. He's like a kid who's been driven in first gear the whole time just to keep up with his mates. And so when we hit the research about growth and maturation, what we can see here, if you observe these two x-rays, is that the one on the left looks as though most of the carpal bones are missing, versus the one on the right's got all its carpal bones. And there's a difference between how distinct the golf ball to T-peg analogy is in the metacarpals and some of the other bones, with the one on the right looking like it's much, much more closely linked to an adult structure. But these two kids are the same age. And so effectively what you just need to remember is that some kids could be up to 3 years behind their chronological age, and some could be 3 years ahead. If we took that age 9, some could have a body of a 6-year-old and some could have a body of a 12-year-old. That could mean that there's up to 28 centimeters in height or 8.6 kilograms of fat-free mass in a pubescent kid. So is that fair when they're playing rugby? And so it's not just about weight. A lot of this is about long levers, skeletal maturity, and testosterone. We're not going to get stuck into this, but again, on the KidsBack2Sport website, you will see that there's a whole handbook on growth and maturation and assessment of it. And it's a complicated topic, but we can use the Camis-Roche method that's on the Bath University website in order to predict how tall the child is going to be. Once we know how tall they're likely to be, and that's usually accurate to within about a centimetre or so, we can take the age they are now and work out a percentage. That percentage basically tells us when they're going to do that big growth spurt. It occurs at around 92 to 93% of their predicted adult height. But what we know is that that's the age they're most likely to, for example, get Osgoods. Just after that, they're most likely to get a PARS. They're not likely to get a muscle injury before 92%. So they'll get lots and lots of those APOPs around the foot, but they're not going to get hip pathologies that are to do with the APOP area. So all of this is really, really helping to build a picture. So I ask you again, Andrew at this point was 19. His hamstring was not mature. So effectively, he was at risk, if I let him play, of developing a ischial tuberosity avulsion. And that's going to be radically differently managed. I'm certainly not going to stretch him, and I'm not going to let him do any deep squats or deep deadlifts. Probably the same management in some respects as a high hamstring tendinopathy. But in that injury, there's no risk of avulsion. So this guy needs to power down, and he basically is going to be out for around 16 to 20 weeks if he has an avulsion. That's not the same as the timeframes that we're going to predict if we're managing a high hamstring tendinopathy. So our APOP injuries can either be acute, like the one we've just described, this avulsion injury, or they can come on gradually and more what we call an apophysitis. So we need to think of these as two separate conditions. If you look at this picture here, what you can see is that this climber's got two ways that he could fall off the wall. He could either end up with the rope snapping, or the anchor may pull out of the wall. In my analogy here, what I'm looking at is that the child has got this very immature and slightly tenuous connection to the parent bone. So if we go back to that ischium, the ischial tuberosity and its tendinous attachment is way more likely to pull away from the pelvic bone. The anchor could come out of the wall. That's the kid's pathology. But the adult, that attachment has fused and therefore has become osseous, strong, and it's the capacity of the tendon that is going to be most likely compromised in the adult patient, and so they are effectively like the rope snapping. So we can see here on this x-ray what happens. And if you've got a separation of more than 15 millimeters between the ischial tuberosity and the parent bone, the child will need surgery. It's going to need to be screwed back. So again, our management is different. So we absolutely need to understand where this kid is in terms of maturation. If you look at the iliac crest, they don't look as though they fused yet, which then gives us a heads up on roughly what age this child is. And how do we recognize when we're seeing an avulsion? Well, in around a third, it's easy. About a third go, it went pop. They basically can come in and they go, Angie, I felt like I'd snapped my bone. I felt like I heard a big pop or a crack. They're easy. And they occur during those maximal intensity sprinting, kicking. It's when the guy kicks the ball as hard as he can. And basically, you can see in this instance how a rec fem is going to avulse from the AIIS in those intense kicking efforts. The significant thing is that they test weak. So a high hamstring tendinopathy, for example, it'll hurt, but there shouldn't be a great deal wrong with the strength, not relative to an avulsion, which has lost its capacity to generate force. So the critical bit here is exquisite tenderness over the point of attachment of a bone, plus or minus a popping. It's a bit like an ACL. Some have them, some don't. But most importantly, we need to get our dynamometers on these to see what the muscle strength is. If they've got a classic presentation and they hurt like hell and they can't weight bear, we clearly can't start our resisted muscle testing until later. But effectively, as soon as they've got that tenderness locally, not over the hip joint, we know we've got problems. So we're starting to use this analogy of, well, can I play with pain? That's always the question that the kid is going to ask. If they've got an APOP below the hip, so like in the knee or in the foot, which we're going to go on to, then yes, they can play with a low level of pain. But if we've got any risk of an avulsion up at the pelvis, or they've got a bone stress injury, which again we'll talk about in a second, then my requirement is they're powered down for probably at least a 12 to 16 week period. So let's think now about the chronic APOPs. If we think about the one that everybody's heard of, it's severs. So here's one of my key points is that pain at a tendon insertion in a child is more likely to be an APOP than a tendinopathy. That's not to say that you don't get any tendon pathology, you do. Within the Osgood's literature, we've discovered that you can get this neovascularization into the tendon, into the local bursa, but they're not the predominant features. These are bone injuries, they're not tendon injuries. The tendon may be implicated, but the driving force is a bone stress. And we need to remember that in our management. Growth occurs from a distal to proximal direction, as in the kid's feet grow and they look like they've got flippers. Then they kind of look like they've got legs up to their armpits, and then they start to get spinal growth. So it's important that we remember that, because what happens is the APOPs, those growth plates, open at a time when there's most active growth. So effectively growth starts in the foot. So we see our fifth metatarsal APOPs and our calcaneal APOPs. As we move up through growth, we're going to start to see them at the tibial tubercle, so your Osgood's, and then ultimately moving into the pelvis around the age of puberty. So it's easy to track where these APOPs were, and that will help you to decide, as long as we know when those areas fuse, whether this is likely to be an APOP or maybe a stress fracture. So think about this case study for a second. If a young soccer player comes in with heel pain and they both get wake up with pain the next day, they've both got worse on activity and it eases with rest. They're both tender to touch and they've both got full range of movement at the ankle. But the critical difference is one is 11 and one is 16. So when you start to think about how do we decide whether this could be a potential severs and an APOP, or whether there could be something else going on. If we start to think about our severs, or what we really should be calling it is calcaneal apophysitis, then there's multiple forces going on, and this just typifies any of the APOPs. We traditionally think about it as being a traction apophysitis of the calf muscle on the insertion at the Achilles tendon. But have you ever thought about what else attaches to the calcaneal growth plate? We need to regard things like your plantar fascia and its distal traction forces. We need to think about compression of the bursa and how basically we're getting a shearing of the growth plate. But it's not a disease. And this is something that I really, really want to take forward with your group being a very influential feature in the MSK world, is that we need to start calling these by the actual anatomical name. It's a calcaneal APOP. It's not severs, and it's certainly not disease. So if you think then between these two children, one is 11 and one is 16. When we look at that calcaneal APOP, the APOP opens between the age of 6 to 8 and is active until the ages of 12 to 14. So even within that very late maturing athlete, it's incredibly rare to get a calcaneal APOP after peak height velocity, after puberty. So if the kid's 16, he's likely to have gone through his growth spurt, and that eliminates our diagnosis of severs or calcaneal apophysitis from our differential diagnosis. And so what I see most commonly when these kids aren't responding like you expect them to do, whatever age, then effectively you've got to remember that some of these have a bone stress injury. So effectively here we've got this kid has got a calcaneal stress fracture, and it's all about the age of onset because the management is radically different. I've got a kid who was 12, he had a vitamin D congenital deficiency. I diagnosed him as a calcaneal APOP, but 2 weeks later the pain was worse. That shouldn't happen if I've powered him down a bit. And so I then got MR scans done, and we discovered he had a stress fracture, and he ended up being booted. I've never booted a kid with calcaneal apophysitis, but the management is just so different. And though you then need to kind of go, well, it's not just stress fractures and APOPs. There's a whole pile of other things can go wrong. So I think one of the things is that every kid who walks into clinic with heel pain, we immediately go, yeah, we know what that is. We've heard of severs. Let's diagnose him as severs. But actually, there's a truckload of things that can go wrong, from infections to cysts to tumours, and also some congenital anomalies that occur, such as the Taylor-Crural coalitions. So children do still get nasties, just in the same way as you would do a detailed subjective assessment to eliminate the risk of a red flag occurring. You need to be aware of them occurring in children. With those kids who've got inflammatory pain, if it's bilateral at the Achilles tendon, there's nothing to say that it's not a some kind of seronegative arthropathy or other things that are related to that. So it's massively important that you do your red flags in just the same way as you would with adults. So when we start to think about these chronic APOPs, things like what we've called severs or Osgood's, or proximal tibial apophysitis and calcaneal apophysitis, you'll see very different management. And here I will let the kids play according to a certain set of criteria. And those are mostly based on the work of Mikhail Rathlef and the team at Aalborg University, which I'd totally recommend as a source of really good reference for the paediatric athlete world. But what the critical part in my one is, yes, they're not allowed to play with pain that's more than a 2 out of 10. It's got to be less than 3. But what does that mean to a child who's never had pain before? And truly, are they representing like a visual analog scale as pain, or is it the frustration that we won't let them play? So mild is probably a better word. But it settles within an hour. It's no worse the next day and doesn't increase any swelling. But the bit that I've added in is it doesn't cause them to limp. No child should be playing if they're limping, they are unable to throw in the same way. So if you think about a change in technique as being your criteria, it's much easier than a subjective, well, does it hurt at more than a 2 out of 10? If you're watching and you've got observable objective changes, then that can be helpful. So let's move it on. I said that the differential diagnosis list is quite extensive in kids. So really what we've got to be saying is, if we've got somebody who presents with joint pain and they've got a temperature, and we need to ask about a recent virus, a recent temperature, because if you've suddenly got a loss of range of movement, particularly we see these in the hip, but I've just had a kid with one in the femur, and effectively these kids need urgent medical attention, just like our septic arthritis that we see in the adult population. These can destroy joints in no time at all. So if you've got somebody who's come in with a loss of range of movement, joint pain, usually these kids are a bit younger, but they quite often come in with a limp. The critical part here is, have you had a recent virus? Have you got a temperature now, or have you had one in the last 2 weeks? When we start to think about swelling and locking in the adolescent knee, some of the diagnostic differentials are different. So if we're looking at that true locking, then what we see is that they tend not to get those medial meniscal tears that we see in the older athlete. What they get is a discoid lateral meniscus. They get these osteochondral defects. That to me is my most common one. So if we get osteochondral defects or osteochondritis dissecans, then effectively what you're seeing is they may get some swelling, they may get some locking. It sort of presents like a bone stress injury in terms of it hurts usually to hop and to run. But critically here, if they've got to the locking phase, these guys are going to probably need surgical intervention. They certainly need an MR scan as soon as possible. And the sooner we diagnose these, the more chance we have of keeping them stable and not progressing into a more serious pathology. So important to really get inside, is there swelling, is there locking, and what does that mean? Because it is different to the adult. And what you're seeing here is that osteochondral defect, and they're commonly occurring in different articular surface areas of the femur. It's a really big diagnosis that we're seeing in kids. And I think the vitamin D deficiency that we're observing in the UK is certainly meaning that we're seeing way more than these. So if you've got a kid who seems to have deep knee pain, have a high suspicion index for these osteochondral injuries. It's not growing pains. They don't exist in terms of at a joint. So really, really important that if you've got deep knee pain with or without swelling, with or without locking and giving way, the most common cause is an osteochondral defect. Now, the spanner in the works is the hip, because in children, we don't actually know why. We don't have really an understanding of what the dermatomal patterning is, or different sort of ways in which the pain patterns seem to refer differently in kids. But what we do know is that in as many as around 30 to 40% of hip pathologies, they don't get hip pain. They present with thigh pain, they present with knee pain. So when you've got a kid who comes in with like quads pain, hamstring pain, pre-puberty, it's almost never a lesion in the quad or the hamstring. So they will get problems at their attachments, but they don't really get muscle strains in the same way as we see in a post-puberty child. Once that testosterone's kicked in, then basically these muscles get big and strong, and yes, you can get a muscle injury. But prior to that, you need to be going, it seems a bit weird. There are some really ambiguous conditions, but most commonly, we need to start looking at the hip when we see thigh pain. And that's really important, because there's a couple of hip pathologies that can give us some real problems. One of them is when the golf ball goes for a little wander. That golf ball can slip off the physis. And so this is called a slipped capital, or if you're old like me, slipped upper femoral epiphysis. So effectively think of it like a bit of ice cream beginning to melt and slightly slide off the cornet. And these kids need urgent intervention. If that gets to more than 50%, they'll get avascular necrosis, and really it's a slippery slope to a hip replacement. If we get them early, we can pin them. And quite a lot of these kids are bilateral. So if we see an asymptomatic, they may well get fixed at the same time. So these are ones where you get a loss of internal rotation and flexion. They've come in with sudden onset of pain, maybe unexplained. It might not be in the hip. And effectively, when you examine them and see that flexion internal rotation loss, you need to be aware that these guys need an X-ray. They don't need a scan, they need an X-ray. This shows up really nicely, whereas almost everything else we've talked about thus far will only show up on an MRI scan. So what you're seeing here is that on that X-ray, you can see how the golf ball has slipped off the diaphysis. It's slipped off the T-peg, and effectively you can see why it could impact the vascular status. Okay, let's move up. We haven't thought about low back pain. So the most common cause of low back pain in any child under the age of 23 is a lumbar bone stress injury. We call these PARS defects, we call them spondylolysis, but we really should be calling them a lumbar bone stress injury. So any child who presents with low back pain who is competing in extension-based sports, so by that we're talking cricket, which you can see here, we're talking any overhead, so javelin, tennis, all of those types of sports. And then think about what the lower limb does when it goes to kick, takes you into massive amounts of extension. Our gymnasts, our high jumpers, our rugby players all go into bilateral extension. And all of these are going to put a really big force through this immature pars area of the vertebral ring. It doesn't ossify until around, again, the age of 23. And during that peak growth spurt, it effectively elongates and becomes thinner. And the type of pattern that you're going to see, if you think about that young cricketer again, right arm cricketer, you can actually see the shirt is almost giving you the arrows to where that forces are going to take place. So we see in the overhead athlete, the single-sided athlete, that they're going to get pain on the contralateral side. Within kicking, it's not quite so easy to know whether it's the stance leg or the kicking leg, and the pathologies and the biomechanics of them are different. But importantly here, the kid will present with pain, and it'll hurt when they kick, run, bowl, and then it'll settle. So they rest for a few days and then they do it again. And then they rest for a few days and it starts to get more frequent. But mostly they can still exist in normal everyday life. But what we know is if we could catch them at that phase, we've got a chance of these healing. If we get to a point where they've now got radiation into the buttock, the hamstring, the calf, or it's bilateral, the probability of healing becomes next to none. And so our job is to increase education. This is what I'm spending most of my time doing, getting out there and talking to schools, to athletes, to coaches, and basically saying that playing sport with low back pain is not acceptable. It's too commonly said that all gymnasts get low back pain, but the majority of gymnasts have spinal pathologies that could impact them into adulthood and create some quite serious spondylolistheses. So we work on these as a spectrum, from that bone bruising phase where they're just getting some normal adaptations to a spike in load. As they start to ignore those symptoms, they could easily become an incomplete stress fracture. But at this point, we have almost a 98 to 99% success rate in getting full osseous healing. So we need to power these kids down at the very, very first sign of back pain. All too often, I hear health professionals coming back to me and saying, it was just muscular in the beginning. I've never seen an MR scan that diagnoses a muscle injury in a pubescent child. Later on, they could get side strains, but never in the pubescent age child. Once we start to progress down to these grade 3 and grade 4 bone stress injuries, the complete stress fractures, and those that go on to slip, which is a spondylolisthesis, we have almost a next to no chance of them healing. That means that they're going to easily get rotational stresses. That means they'll probably become bilateral, and then they're going to end up with recurrent injuries, most probably. And the most common cause of a bone stress injury, specifically in children, is a mismatch between energy availability and energy expenditure. By that, I mean that they don't eat enough for what they do. Think about those kids who play multiple sports, running around like headless chickens. How often have they got time to really fuel properly? For those of you who are parents, how often do you have to just shove food in them as they're on the way to fixtures? And do you think about whether that's got enough energy requirements for the sport they do? Do you change the amount of food that they have based on how much and how hard they're going to go? Because if we don't address these energy availabilities, we're on a slippery slope. There's not a chance that these are going to heal. Consider these two children for a second. A 12-year-old male athlete with low back pain, a recent increase in exercise volume and intensity, recent rapid growth spurt, but misses breakfast and lunch most days. And that may sound like pretty radical, but this is common. Kids get up too late, they're night owls. They don't want to wake up in the morning just to eat brekkie. So they run out of the door, maybe grabbing something, but usually nothing with nutritional value as they head out to school. And then most of these kids play sport or go out with their mates at lunchtime onto the playing fields and effectively end up either missing lunch completely or having little bits and bobs throughout the day. Compare that to a 12-year-old female athlete with low back pain, who again has had that spike in activity that we associate with exceeding their current capacity, but on this occasion started a no-carb diet for weight loss. She noticed that her periods had started about a year ago and then they stopped 2 months ago. Same injury, but completely different mechanism. And we split these into unintentional low energy availability and intentional low energy availability. The first kid just didn't have a Scooby-Doo. They had no idea how much they needed, and they're a bit like a car being driven in first gear. If you drive a sports car, you burn through more energy than you do if you're driving and cruising in an old lady's car in fifth gear. So effectively, we need to start to understand the impact of growth, the impact of their rate of perceived exertion, how hard they're working, not just how much. And then we need to get inside the psychology of those that are being driven by intentional low energy availability. We've seen people who are in weight classes, such as the lightweight rowers. In boxing and in the martial arts, they're again in weight categories. We've got athletes who are horse riding, and again, they've got to meet the requirements of their sport. And these basically can really start to head into some pretty serious low energy availability without realizing. What happens is that if you are in low energy availability, the body goes into its emergency mode and it powers down certain systems. I liken this to a mobile phone. When we're in power saving mode, this is how I describe it to the kids. What we see is that you can't use things like games, you can't use videos, but you can still make a text or make a call. And that's in stark contrast to the human body, which says, if I haven't got enough energy for what I need, then I will power down things like reproduction, immunity, repair, and growth. But I'll leave enough there for the cardiovascular system to fight for my life under stress situations. And unless we help children recognize just finding out how much they need, then they're going to start to have a powering down of their testosterone, their estrogen, thyroid, growth hormone. And with that, we'll start to see that bone health is the first system to be affected. And that's really, in my mind, with these kids, the biggest driver behind the high numbers of avulsion injuries and bone stress injuries that we're seeing in these kids. If you're not familiar with relative energy deficiency in sports, we're just doing a KidsBack2Sport video and handbook that'll be out over the next week. But there is lots of information out there in the IOC consensus statement that was released last year. And it's a condition of low energy availability affecting male and female athletes of all levels and ages. This isn't just about girls missing periods. Boys lose their morning erections. They lose motivational drive. There's so many factors that we need to consider because all the systems are affected. And you'll see when you look at the IOC consensus statement, which is free, just how multi-systemic this is. But if you're hoping to build muscles in the gym with your patients and they aren't getting the fuel for what they need, we know that it affects protein synthesis. But it also affects a whole load of other stuff. We've got all of the psychological impacts of anxiety, depression, low mood. We've got lack of concentration. And what these kids usually present with is things like the niggly little injuries where you're looking at the history and go, God, he had ankles last week, knees this week. And they're getting those recurrent viruses, lots of sore throats. And what we tend to see is a drop in performance. they can't get their PBs in running and swimming. And so consequently, we need to be on the lookout for these as clinicians. We're the guys who are going to spot this. And if we can get in early, we're going to make a massive difference to outcomes. The majority of kids in the UK have got low vitamin D, and a whole load of them have got low iron. In somebody who, say, for example, got Crohn's or celiac, then they won't be naturally retaining these vitamins. And so you need to understand the whole athlete. And certainly within the courses I run, we look at that whole pre-assessment questionnaire that we send out to screen for all of these different types of things. But it's so important that we discuss nutrition, vitamin D, or if you haven't got that skill set, then we need to link up with nutritionists who do. I want to make sure that you absolutely change the dialogue. I want to lose words like stress fracture, they're bone stress injuries. Only a minority have a fracture, and therefore why scare the hell out of them that they've got a broken back or a broken leg? We need to lose this word disease. They're no more a disease than they are a part of a misadaptation in the skeletal system, but are really, in essence, a part of growth. And if we learn to manage these well and give good information, we will make such a difference to these kids. I'd absolutely recommend the work of Johansson. And there's lots of different ones. Mikhail Rathlef's another name on this paper, and certainly Ben Smith in the UK. And they've come up now with some really good papers around what does the child need. We all know that we need to have a patient-centered approach, but in a child, what they want is to understand the condition they've got. So if we talk about a lumbar bone stress injury, how are you going to teach the kid what is wrong with them in a non-scary way, in a language that they can use to repeat back to their mates in the playground, to their coaches to explain why they can't play, and to their parents, and so that they don't develop that fear around disease or fracture. We need to give them that confidence and competence to self-manage and really help them to understand how they can be empowered to make a difference. Teach them when they can play and when they can't play. But it all boils down to giving them really good information. And the purpose of Kids Back to Sport is to create educational resources that you guys can use. This is all free. What we want you to do is use links to the website. And if you've got a kid who's presented with a tibial apophysitis or severs, then send them, tibial apophysitis or Osgood's, send them a link to the website. They can download these handouts. Now, you could obviously download them as PDFs, but we don't want you to do that because it limits you in giving out information that might be historical. I change these as often as weekly at times because new research comes out, and these are active documents that constantly get updated. So we want you to use them. Every child you see should read the book on why kids get injured. There's ones around how to boost your performance. There's videos on there as well. And there's the safe return to play modules. So there's tons of information that we can give these kids. The reason why kids get Osgood's having had severs is because we didn't educate them and address the issues of why in the first episode. So to just highlight these 10 things, hip pathology often presents as thigh and knee pain. A painful loss of hip internal rotation, inflection or abduction should be investigated to exclude either perthes or a slip capital femoral epiphysis. A child with joint pain and a temperature or locking, giving way and swelling should always be investigated, and the sooner the better. Pain at the tendon insertion is more likely to be an APOP, and effectively what we're saying here is less likely to be a tendinopathy. In the knee and in the foot, unless there's a risk that it's a bone stress, they can play with a mild degree of pain as long as it doesn't affect the way they move. But once it's up in the pelvis, there's always that high suspicion index for an avulsion, and therefore we need to manage those differently. Extension-related low back pain is a bone stress until you can prove it otherwise, and you need to power these kids down immediately because that risk of going from a grade 2 to a grade 3 is ultimately going to dictate whether the kid heals or doesn't heal. We need to address these low energy availabilities, vitamin D and iron, because we know that there's research bases out there to associate them with the majority of these kids' conditions. and highly important that kids still get nasties. I have seen so few kids over a 35-year career with tumours, but when you see one, it's so emotionally driven. They're not common. I don't want to freak you out, but you do need to know about them. That was a whistle-stop tour. There's loads of ways you can learn from me. I have loads and loads of different resources. So please do look at the Kids Back to Sport website, where you can see courses for you guys, or alternatively, just look at all the free resources. But please do signpost all the clubs, the coaches, the teachers to where they can get this information.
Angela, thank you very much. We don't do a lot of kind of clinical webinars on MSKPN, but this is an area that Jane introduced us to, Angela, for MSKPN, but also that one of obviously MSKPN standards is around driving quality in MSK. So debunking any information, getting high quality information is obviously really important to us as well. The other reason we wanted to do this intro to Paediatric MSK is around Angela's courses. So following this, once the recording's been shared and people have had time to kind of disseminate it within their teams and talk about their learning needs within their teams, and there may be the opportunity for us to group together to have some of these courses so that we can all kind of increase our knowledge in this area as well within our teams. Does anyone have any specific questions for Angela while she is Jane does, so please come in, Jane.
I just want to tell everyone why Angela and I know each other, and really reiterate to the rest of you why it's really, really important. So we do a risk analysis throughout the business from a clinical point of view, from financial and all that other type of work. And I have a team of 20, and every time that we got a new member of staff, the main thing that they said to us was that they were scared of kids. And for good reason, because their educational background around children was really, really poor. So we looked at the risk analysis around children, and we felt that the whole team were at risk, and therefore the business had some risk elements to it. So from a business point of view, I think everybody who has a team should really look and take this seriously. We have a lot of children coming through us that are quite high level, and we felt that it would be the right thing to do, and it has been absolutely fantastic, and it has gelled our team together. We put 90% of the team through the whole course. It's very extensive. It's a lot of online learning. It's very involved. It's very detailed, and I can't thank Angela enough, because it's really been absolutely fantastic, and it makes me sleep better at night knowing that the right thing has been done as well. The team have really, really embraced it, and it takes a long time to do, but they've seemed to have pride in what they're doing and pride in what they're learning. It's not a short course. There's lots of different ones, and Angela can tell you herself, but we brought Angela down for 2 days, and interspersed with that, they had a high level of online learning, which is really high quality. So if you're going to invest in something this year that has business elements to it, I think that there's going to be a definite growth in children's services. We don't have any good NHS children's services near us, so we not only provide a brilliant service now, but there's nowhere else for them to go that is anywhere near as good as we are. So I think from a business point of view, it's really, really good as well. So I just want to sing Angela's praises.
Oh, thank you, Jane. I think what's really important is that we've set Sevenoaks Physio up as a super centre within their region. They're on the Kids Back to Sport directory, so parents can find them. And that's really my business model. I was a clinic owner for 30 years, and basically we used to market, go into schools, give educational talks, and within the course, that's one of the things we teach, is how to deliver a education seminar to local clubs and schools. And importantly there, what we can do is hold your hand and get you set up so that you're basically promoting your services. And we used a kind of slightly different business model, but it was one that was massively successful. Once we'd got that kid in, the parents sat there going, well, I could do with a bit of that on my shoulder. And we'd then be able to embrace the shoulder. And then granny comes along. So as opposed to suddenly ending up with an odd kid because some parent's happy with your clinic, that has then basically brought their kid along. We did it the other way round, and we built the most wonderfully successful practice up in the Cheshire area that was based on this educational model. We educated the community, and then they came to us in droves.
That's brilliant.
Are there any clinical questions? Okay, cool.
We'll share our Angela's details on the WhatsApp group, and obviously the recording will come around later today or sometime this week. But thank you very much, everyone, for joining, and thank you very much, Angela, for your time for us all.
My absolute pleasure. It's been really lovely to meet you all. Thank you.
Bye-bye.